Marcelo. Yeah. Okay, good afternoon, everyone. I'm Steve Pastoris from Memorial Sloan Kettering Cancer Center in New York City, pulmonary critical care. Seeing a number of you, I think we all know that this is a topic of considerable interest to all of us who manage patients on mechanical ventilation, and we are delighted to have two of our world's best experts to talk to us about PEEP, and that there is an optimal PEEP for every patient on mechanical ventilation. And we'll start with Dr. Marcelo Mato. Thank you.
Thank you. May I have the first slide? Yeah. I like to do this preparation. So we just take out the lung from an animal, and the animal obviously is dead, and we ventilate, and we try to understand how much pressures we need to best ventilate this lung. And I took some guidance from old physiological studies, and these studies, they were telling me that for most mammals, if you are ventilating the lung against air, surrounded by air, no pleural pressure surrounding the lung, the closing pressures is +2, maximum of +4, but it's a very narrow range, as you can see in this table. So we have +2 with a very narrow range between 1 and 4. So we did this PEEP compliance curve in this lung. This is PEEP. This is lung compliance. And there is an optimum point at 2, and it's a very sharp point. And as you can see, if my PEEP level is 8 or 10, my compliance is already 1/4. So +2 is the best compliance in this case. And I can read PEEP here as transpulmonary pressure because I'm surrounded by air. So it's 0 pleural pressure. So best PEEP at +2 transpulmonary pressure. So I repeated these experiments in some lung injuries, some normal lungs. I always got the same result. So for instance, in this animal, again, transpulmonary pressures of +3. And I took this preparation, isolated lung, to the CT to understand what was going on and what was causing this sharp decrease in compliance at a low transpulmonary pressure. And as you can see, there is absolutely no lung collapse except when you are below this threshold of +2 or +3 of transpulmonary pressure, a very sharp threshold, and you start to see many red dots. Series of lungs, same results, always between +2 or +3. All the lungs were getting some collapse, especially airway closure collapse. So if you look outside, it's not much changing in terms of the color of the lung, but functionally, the lung is not working any longer. So it's truly airway collapse. So again, transpulmonary pressures of +2 and +3. So when we do PEEP titration using EIT, our hypothesis many years ago is that we have exactly the same curve that we get with an isolated lung preparation, except that it's inside the chest. And the very reason for this is because with EIT, we are almost, let's say, visualizing the lung. And then you can easily calculate also transpulmonary pressures. So the absolute numbers are very different depending on the position. But the changes in transpulmonary pressure are very similar all over the pleural surface. So, which means that this curve can be considered precisely the equivalent of this isolated lung preparation, where I have a sharp point of best compliance, and then if I'm below this point, I have collapsed unis. If I'm above this point, I'm having hyperdistension. The problem is that each pixel in this image has a different curve because it is in a different part of this curve. So if I do the same curve, for instance, for this yellow pixel, I will get this curve. If I do the same titration curve for this green pixel, I will have this curve. Okay, so it looks like that the curves are moving, but because the x-axis here is PEEP, but let's make it easier. Let's put the same axis for all the pixels. Let's put transpulmonary pressures, and then all the pixels, they get collapsed into the same curve. And now the yellow is going to be at a positive transpulmonary. For instance, if I'm using this PEEP level, which is 15, the yellow is going to be at a transpulmonary pressure of +4, hyperdistended. The green is going to be at a -1 or -2 transpulmonary pressure, and it's going to be collapsed. So if you look at a CT and you think about this curve, and let's suppose that this is the esophageal pressure that you're measuring, and you're setting your PEEP at a transpulmonary pressure of +2. This means that all these red zones are going to be above this transpulmonary pressure. So the yellow dot is going to be here. And all the pixels below this set level of superimposed pressure, they are going to be in the collapsed zone. And indeed, this CT is proving that this is the fact. Every time I see a CT like this, I know that the transpulmonary pressures here are negative. So we did an experiment in extreme obese, and then this was with the help of people in Boston. So the crossing point between collapse and hyperdistension was exactly at a transpulmonary pressure of 21. But this corresponded of a transpulmonary pressure of +2, again, as should be. It's just that it's very far away from the situation of an isolated lung, because this lung is buried inside this patient. Collapsed curve, hyperdistension curve. I have a little bit of collapse happening in the regions downwards, the esophagus, and a little bit of overdistension of all the regions that are above this level, supposing that I'm using a PEEP level of 21, which gives me a transpulmonary pressure of +2. This is why, when we measure esophageal pressure with good precision, and I do a full recruitment, I always started to see some collapse when my transpulmonary pressure is getting close to +2. So if I can find these numbers at the bedside, this would be wonderful, because it's a general solution for all the mammals and, I guess, for our patients. We have explained that when we have obese patients, and we did these experiments in animals many times, by just putting some weights on top of the abdominal cavity, and what we get is that we realize that chest wall compliance doesn't change. It just suffers a shift to the right, which means that those principles apply. I'm just shifting the curve to the right with the same chest wall compliance. And to prove that this is true, we did the PEEP titration without weight, and then I have this crossing point at 5. So very low PEEP requirement for this animal. Now I'm going to put some weight on top of the chest and abdominal cavity. I get the same curve, but displaced to the left, with an optimum PEEP of 14, the same maximum compliance, same amount of collapse and overdistension, if I consider this shift. But certainly at the bedside, you choose some PEEP, for instance, of 10. On the left, I have the animal without weight. Now I'm going to put some weight, and then I see a lot of collapse. But if I use some PEEP for this animal and apply the same principles, I would get exactly the same result here, just increasing my PEEP level. This is just a shift caused by the weight and obesity. When I'm using high PEEP, it's interesting because the animal without any weight was overdistended, and then with a very low compliance. And then when I put the weight, hyperdistension is gone, much less, so from 75 to 28%, and I have much lower compliance. Same for position. If I do train Dallenberg, I have a shift of the curve, and the crossing point is set at a different PEEP level. Here is 11, and here is 16. So I think all these problems happen at the bedside, and then in a patient with COVID, we tried to, in a series of patients with COVID, we tried to apply the same principles. And we were imagining that the problem of decubitus atelectasis was pretty much related to the fact that we ventilated these patients for a certain period of time at negative transpulmonary pressures. How much PEEP you need varies a lot among patients, but we can track if we are using electrical impedance tomography. You see the spreading, even for normal lungs, is very big. So if you don't have monitor at the bedside, you cannot do it. But what happens if you apply it? First is that this PEEP requirement is not necessarily high. It's just different from the conventional approach. So this is the approach in which we follow oxygenation based on the ARDSNet table. And then this is this physiological approach trying to match this precise PEEP. You can see that in some patients, I have to increase by almost 10 centimeters of water, and some other patients, I have to decrease by more than 10 centimeters of water. And certainly in obese patients, I need more PEEP. And then what happens with the driving pressure? Driving pressure decreases by 4 or 5 centimeters of water with this individualized approach. And this is sustained along the time if I keep the same PEEP level. So my conclusion is that there is an optimum PEEP to be set at the bedside. The real problem is we need good monitoring and to set it right. Obviously, lung history is very important, and then to keep this, let's say, this benefit in terms of compliance, you have to sometimes to repeat the procedure along the days, but it's feasible, and we have a proof of concept. Thank you very much.
Thank you, Dr. Amato. We will bring up Dr. Luciano Gattinoni and take the con side, that there is no optimal PEEP for every individual patient in the ICU.
Well, it's a difficult topic, and with Marcelo, I think we discussed this since decades. But well, let's give me my point of view. I have the counter side. So, what is the optimal PEEP? We love the word optimal, best, beautiful, hübsch, wunderbar PEEP. Great. Should provide optimal gas exchange. What is optimal gas exchange? Is optimal. That's it. Must be keep the lung open. And Marcelo with Amato for years said you have to use great PEEP to keep the lung open and so on. Then you have to avoid alveolar overdistension, of course, because alveolar distension is very bad. And this is more neglected. You have to not compromise the hemodynamic because I think that Marcelo presented a beautiful showing that the transpulmonary pressure OS plus 2, which is exactly what a normal man at end of expiration is not a bad things. But if you want to use the positive intrathoracic pressure, which is PEEP, we are not built to have positive pressure in the thorax. So all these are just impossible. PEEP is always a compromise. And I appreciate that now Marcelo shifted for keep the lung open, whatever it costs, to wait. Be careful, there may be some overdistension and maybe some collapse in the other side. And is a first step in a long way. But let's see. Apparently today we found the Holy Grail because we start, to me, with the best approach to PEEP available now. Was found 50 years ago, was described 50 years ago by Peter Suter. Because he just put it together, the mechanics, the gas exchange, and the hemodynamics. So he found the best compromise with this. After that, we have a series of history in trying to set the optimal PEEP, which are in the 80s, we had in Miami and in France, well, you have to reach 15% of shunt. Who cares about the rest? And you increase the pressure, and the pressure was 25, 20, 25, and of course, nobody was taking care of hemodynamic. Then we started Dansker to say, no, wait a second. If I have 1 liter of blood flow, is easier to be oxygenated than 5 liters of blood flow. Any times you decrease the cardiac output, the PO2 goes up. But everybody was looking to oxygenation. Then we discovered the volume pressure curve. And we had that beautiful curve, very sexy, as sigmoid, when you have in the lower part bad because atelectasis. Then we have the safe part, the straight part, and then we have the overdistension in upper part. Unfortunately, the recruitment occurs along all the curve. Then we have the open lung strategy. I already touched that, which proved to be a little bit dangerous. Then we have the imaging. And the imaging, one thing is the CT scan, and the other thing is the AIT. Because all these numbers on AIT, for what I understood and not an expert, are just assume that the changes in impedance equal the change in the gas volume. Then you have the pressure, you make the division, and you have the compliance, which is exactly as when you do, taking as an example, dual curve, are all based on one assumption, that the changes in compliance equals a recruitment, which is simply wrong. It's not that. Now, the next. So, these are the best people, really. These are best people are mechanics, I say you. This is the ideal, the classical curve. We know that we have a recruitment all over the inflation curve, and then keep all the lung open. Another fascinating theory. Unfortunately, to keep the lung open, completely open, and remember that what's open the lung is the inspiration, not the expiration. But if you have 45 of pressure and you want to keep all the lung open, you have to keep the lung at least 23, 25 centimeter water pressure in the general population. At this pressure, you just have some problem with the hemodynamic, and not just to maintain the pressure. You can do it. You give 3 liters of water, and you give some cardioactive drug, and say, what is the problem with hemodynamics? I control the hemodynamics. Unfortunately, the patient gained 3 kilos, and as soon as you decrease the PEEP of 2 centimeters of water, you have the lung will start to collapse because you make atelectasis, because you increase the edema of the lung. So the price that we pay, and when you have 15 of PEEP, you have at least the same grams. This is one study which has been completely neglected because it's out of the current thinking, but we clearly measure the amount of opening and closing between plateau pressure and PEEP when you have the PEEP of 5 and when you have the PEEP of 15. And even at 15, you have a consistent amount of opening and closing. And now I read some strange guideline saying, after the recruitment maneuver, don't touch the PEEP. That means you recruit a lot, then you start to opening and closing until the lung close again. When we have 30 centimeters of water of plateau pressure, about 1/3 of the lung, the potentially recruitable lung, stay closed. And maybe it's good. If I open up, I just increase the gymnastic of the lung. But in the last 4 or 5 years, I just did experimental work, trying to look to destroy the lung with a mechanical ventilation and try to protect or to see the body reaction. And what to me, I'm extremely impressed that the real or the main problem of what we call the VILI, which is increased edema, is hemodynamic. The lung per se is extremely resistant. To destroy a lung, we have to use really a lot of pressure. But the lung has the heart in one side. It's not an isolated organ. And these are more than 100 peaks, I think. And you see one, excuse me, well, anyway, one line which was very higher, completely different from the others. This was the line of the high PEEP, in this case, very high. Oops, excuse me. You see here, this is a tremendous line. During a PEEP, with a high PEEP, and it's not, the edema in the lung is not much worse than with other approaches. But the total water that you give to the body is is terribly high. So all the organs start to suffer, not only the lung. And why so important the hemodynamics? Because when you have PEEP and very high PEEP, you don't have a single second in which the hemodynamic can flow, the blood can flow freely into the lung. So, best PEEP and clinical trials. So you can do whatever meta-analysis, whatever reconsideration of data. You can call the great statistics. They can 3 pages of statistical approaches just to show that when you compare volotrauma, benefit and risk, that means lower PEEP, and volotrauma, atelic trauma, benefit and risk, which is low PEEP, or benefit and risk of higher PEEP, was very clearly show that in the general population, if you play the game between 7-8 of PEEP and 15-16 of PEEP, these two techniques, two approaches are equivalent. Risk and benefit of volotrauma and atelic trauma are the same. But then you want to increase the pressure. And Marcelo has to pay me back one bit we had a few years ago, right? Remember that? Dressed as a monk about this study, because this study clearly showed, because it's a positive trial, that if you play with a higher PEEP than 15 and so on, the volotrauma wins. If you add as a salt and pepper some recruitment maneuver, even worse. So, which are my conclusion? That optimal PEEP then means an absolute value of PEEP, which is good for everything. That means satisfy all the theoretical requirements simply does not exist. You may have a compromise. The best compromise is the balance between over-distension and keep the lung closed, as an example. And this is absolutely a reasonable way. The problem is how you measure that and where you set the balance point. But I think it's a promising way to go. And what we have now, we know now what we must do is to avoid the harmful PEEP. Because any time we play with the mechanical ventilation, we just buy time. And we have to buy time at the lowest iatrogenic cost possible. So I'm far more interested to avoid damage. Anytime I touch the knob, this set is more or less dangerous? This is the question that we have to answer. And then to accept a compromise, as in many other aspects of our life. I thank you for the attention.
Thank you. There's another session following very, very shortly, but we probably can just get a minute. It's a pro-con session, so I'll ask Dr. Amato to just counter Dr. Gattinoni's assumption that as much as I like physiology and I like to base my settings on physiology like Dr. Amato, I'm also kind of convinced that it's really a risk-benefit. And so I'm never below 5, but I'm never below or above generally 15. So my sweet spot has been in that 10 to 15 range, but I'll let Dr. Amato share his views about that.
Thank you. According to this new or old approach I'm proposing, we never got numbers above 20, but we have lots of numbers around from 5 to 10. So I was surprised to see. So the sweet spot is a little bit wider than what we want. And then secondly, I just one very hard topic, which is this monk dressing that I owe to Luciano. But about the art trial, I think it's very important to keep in mind 3 big mistakes which were done. The first one, just to give you an idea, 1/3 of the patients in this trial had an increase in driving pressure after randomization, which means that the choice of PEEP was completely wrong. So wrong methods at the bedside. Secondly, I have talked a lot about this. They used volume control with 5 mL per kilogram. So the amount of breath stacking was so huge. I think I'm guessing something like 80% of the patients on top of a high PEEP. And so this was a disaster. And finally, I think there was a minimum level of people which was 13 applied to patients like Oriental people in Brazil because they are Indians. And these people typically, when I do titration, they need just 5 or 8 of PEEP. So I think it's just, so we learn a little bit like also we learned from the old prone trials. So I hope we make, let's say, smaller mistakes in the future. Thank you very much.
Thank you. I'll give a minute for Dr. Gattinoni to refute that, and then we'll close the session.
Well, not even less. I'm glad that Amato is the 3rd conversion I see in his life, which is good. Means renovation of the spirit. I just want to note, when I was very young, we had a servo C machine. And the servo C machine has a beautiful things incorporated. The green mark. Tidal volume, green mark. Total ventilation, green mark. PEEP, green mark. With this green mark, you don't kill anybody. So I think, even to start, be careful when you start with a table that gives you 20 of PEEP. Because when you start with this table, to give 20 of PEEP, you you fill the patient with water. And then you decrease the PEEP and you change completely the condition. So please start, I would suggest, around 10, and then sit down, think to the physiology, and wait and see. And 10, I think, is at the end of the story, I don't think will be very of Amato, but something between 7 and 15. 15 is already, and all the rest, the lunches or compliance. A possible exception may be a very severe obese patient, which is a particular effect that make me thinking a lot about the causes of is the real explanation of that. But I agree with Mark, with Amato, that the chest wall elastance is absolutely normal in this patient. Or even, okay, thank you, and please don't harm. That is not ideal, but there is the killing PEEP. Try to avoid it.
Thank you to our experts. Question? Okay.